organization in the Please mention your name, title, and organization in the chat box. We will start a formal welcome followed by setting context of the discussion. We then have plenary talks by our speakers. After the talks, I will explain you the process of joining the breakout rooms in this very session. Kindly note that the session's plenary talks and the way forwards will be recorded. Breakout session discussions will not be recorded. Please feel free to use the chat option to send in your suggestions or questions anytime during the discussion. Let me start by introducing Dr. Helga Fogstad. Dr. Helga is the Executive Director of the Partnership for Maternal, Newborn and Child Health, PMNCH. Her prior associations have been with the Norwegian Agency for Development Cooperation, NORAD. She's strongly committed to human rights, public health, and gender issues. She's a health economist with over 30 years of proven experience. We are fortunate to have you with us today, Dr. Helga. Over to you.
Thank you so much, and I'm delighted to be here. So on behalf of the co-organizers, the Partnership for Maternal, Newborn and Child Health, and the BRANCH Consortium, and Aga Khan University, we warmly welcome you to this workshop. In light of the current evolving security situation in the region, which I know you must be so preoccupied in responding and adapting to, we are especially grateful that you are all joining us today. We know that you will agree that this workshop is happening at a critical time. Now more than ever, we need to be discussing and looking for ways to prioritize in response to the health and well-being needs for women, children, and adolescents who are the most vulnerable in the face of any conflict. At the vast body of branch evidence, as illustrated with high levels of insecurity, population movement, disruption in supply chains, and exacerbation of pre-existing shortages of human and financial resources, all issues that are now unfortunately being seen in the region. It is especially difficult to deliver quality services to women, children, and adolescents. We further see that COVID-19 is unfortunately making it even worse for vulnerable situations, erasing even gains made to date. It has led to widespread disruption and shaken the health system foundation in even the most stable settings. And while the evidence is sparse, it is in areas hit by conflict where the devastating impact of COVID is being felt the most. It is important at times like these, we are not overcome by the challenges that deliver care to women, children, and adolescents in these the settings that these pose, and that we support and advocate for evidence-based decision-making, including equity, enhancing allocation of resources, and prioritizing of essential interventions and services to women, children, and adolescents. The BRANCH Consortium has done a vast and critical amount of work trying to unpack all of these aspects through country case studies and systematic reviews. And we hope through your participation in this workshop that aims at advancing the uptake of robust evidence, we can discuss with you how the evidence can be leveraged to drive more responsive policy, financing, and action tailored to the need of your communities. Ultimately, we all know too well, responding to the needs of women, children, and adolescents in conflict settings hinges on political will and on our efforts as the health community to shift that political will, that will to protect their health and well-being, especially in conflict settings. The will for a multi-sectoral approach and equity enhancing investments, addressing all the determinants, social, economic, cultural, political, environmental, and commercial, of a woman and an adolescent and a child, that including their caregivers' health and well-being. At PMNCH, which is the world's largest alliance for women and children and adolescents' health and well-being, with over 1,000 partner organizations. With advocacy as our core function, we have been focusing on driving that political will through equity-enhancing country commitments, be it financial, policy, service delivery commitments, that are all important in line with the COVID-19 call to action, so that every woman, child, and adolescent is able to realize their health and well-being. No one leaving no one behind. We will provide again the link to the call to action in the chat box. The BRANCH Consortium also notes how important it is for the global, regional, and local health communities to align and have a unified understanding and approach to humanitarian action for women, newborns, children, and adolescents in conflict setting. Today, you are surrounded by an expert group. You are surrounded by an expert group of people ranging from frontline and humanitarian workers, local civil society members, leading academics, youth advocates, and policymakers, all striving to serve their communities. I hope that we are able to come together to pool our experiences and forge a way forward through which we can really make a difference collectively. We are committed to working alongside you at the country and regional level to safeguard the needs of the most vulnerable women and children and adolescents, wherever they may be, and hope that through this workshop, we are able to build the multi-stakeholder links that are needed to help realize every woman, every child, and every adolescent's right to health and well-being. I look forward to really the deliberations of this meeting that should result in effective actions. Thank you.
Thank you so much, Dr. Helga. May I please invite two very seasoned public health experts, Dr. Shafiq Mirzazada from Afghanistan and Dr. Rana Safdar from Pakistan. Dr. Shafiq and Dr. Rana are representing governments of Afghanistan and Pakistan respectively. Dr. Shafiq, may I request you to please start by setting the context, and then Dr. Rana may take the lead.
Thank you, Asghar. Excellencies, colleagues, ladies and gentlemen, good morning, good afternoon, good evening, wherever you're based, and assalamu alaikum. I'm happy to be here with you during this workshop, very important workshop on the health of mothers, newborn children, adolescent health. And Afghanistan is going through a difficult time due to escalation in recent conflicts. Looking back at Afghanistan's past 4 decades, the country has been dealing with conflict at different levels and different times. In year after 2001, there was a period in which Afghanistan benefited from a time of lower conflict that allowed the country to develop and implement some very important development agenda in all sectors, including health. For example, the implementation and development of the basic package of health services and essential package of hospital services, to a very well-structured contracting out mechanism through non-governmental organizations with the support from our donors and partners. During these years, significant gains were achieved in health and other sectors. We know that the maternal mortality ratio, infant mortality rates, and under 5 mortality rates decreased significantly. Nutrition status of women and children improved Immunization coverage for children significantly improved in these years, though the improvement varied in different regions of the country due to a number of reasons, including but not limited to insecurity and conflict. Unfortunately, due to latest unrest all over the country, there is a fear of losing these achievements of the past years. Though the health system and the people of Afghanistan have shown resiliency in keeping the system functioning despite escalating insecurities, we believe that the people of Afghanistan and the government of Afghanistan will overcome these challenges and will once again thrive. As you know, that the pandemic has added another burden on the health system and the people of Afghanistan, but the system once again showed that it has the capacity to protect people from the virus. The Ministry of Public Health is committed to provide services to the most affected population, including women, children, infant and adolescent, and make sure that people in general and women and children in particular have access to basic services. During these months with the conflict, the health system has once again showed its commitment and resiliency, and I would like to salute the health workers of the country for their commitment and dedication. The workshop today will definitely provide insight on how to mitigate risks posed by conflict on the reproductive, maternal, newborn, child and adolescent health services, and finding barriers and enablers for implementing RMNC services, as outlined in the workshop program. And I really look forward to contributions from all colleagues during the plenary session as well as in the working groups to actively participate and provide enough and sufficient recommendations to the governments and the people to make sure that the services are provided through innovative ways to the people. At the end, I would like to take this opportunity to thank you all for participating in this very important workshop. Thank you very much.
Thank you so much, Dr. Sri. May I please request Dr. Rana Safdar from Government of Pakistan to kindly give us comments.
Thank you very much. Thank you, Brother Shafiq Mizada and all other colleagues. I bring greetings for all of you from Islamabad. And I actually feel personally honored to be part of this very important workshop, where I am going to share my thoughts as the Director General Health of Pakistan, and also a National Coordinator for Polio Eradication for over 5 years. Let me begin first by appreciating the organizers of this very important event. It is indeed of paramount importance to highlight that how conflicts have been ravaging the lives and well-beings of the citizens around the globe. We, the two border-sharing countries, have also been facing the consequences of conflict for past 3 decades. Afghanistan much more than Pakistan. Effects of war and conflict are profound and far-reaching, extending well beyond the battlefield, country borders, and period of the active warfare. Moreover, the nature of conflict has changed dramatically over the years, with the asymmetric and unconventional warfare often resulting in civilian victims, which outnumber the combatant casualties significantly. Pervasive conflict and violence adversely affect the health and well-being of the populations, both directly and indirectly. Wars result not only in damage to the health infrastructure, but also cause deterioration of the key determinants of health, including the economic, social, cultural, environmental, and political systems which hinder the provision of healthcare to the poorest, enhancing the health disparities. Not surprisingly, the most vulnerable, that is, women and children, are left to fend for survival in environments with high risk of disease, disability, and death, including the miseries that they suffer in the camp areas with risks of exposures to rapes and assaults as well. Fewer antenatal care visits during pregnancy, combined with the increased prevalence of both high-risk abortions and prenatal infections, as well as poor maternal nutrition during the times of conflict, result in more maternal and newborn deaths. Under these circumstances, the availability, accessibility, affordability, and acceptability of the health services decline significantly, again causing a reduction in their utilization to whatever extent they are available. The funding, social networks, and collaboration of development partners can certainly provide a valuable opportunity for the governments and donors to ensure health equity in the wake of the conflict. However, sustainability of such ventures is again an irremediable issue in the long term. Working together with a collective sense of responsibility provides us the best opportunities to succeed. Talking of our own example, Pakistan built 3 tertiary care hospitals in Afghanistan, including the 200-bedded Jinnah Hospital in Kabul and 60-bedded kidney center in Jalalabad and 100-bedded hospital at Logar. Pakistan further continues to provide training of the postgraduate specialists, physicians, and paramedics to staff these facilities. Moreover, we have also allocated seats for Afghan refugees in our medical colleges to compensate for the lack of medical colleges and institutions in Afghanistan. As the last 2 polio-endemic countries, Pakistan and Afghanistan are also striving together to fully eradicate this menace from the globe. And as a matter of fact, our coordination in polio actually sets an example how we can work collectively to overcome such like challenges during conflicts. Thanks to the excellent joint planning and implementation of our very well coordinated vaccination activities, only 2 wild polio cases, 1 each in Afghanistan and Pakistan, have been reported this year, highlighting successes being booked for the health and welfare of our children aged under 5. Dear colleagues, it is critically important to understand and resolve the root causes of conflict. Addressing health inequities in the long term necessitates addressing state fragility, since peace and effective governance underpin the development of equitable health systems. Strong health systems remain imperative to tackle such like challenges, both during conflicts as well as when we are out of conflicts. At the end, I would like to emphasize that further research is needed to quantify the impact of conflicts on the magnitude of inequalities in mortality or coverage of RMNCH and immunization services in conflict areas. New strategies and interventions to improve service delivery should be instituted, and these efforts can be fruitful only when we collaborate and build effective strategies. I hope this workshop brings forth a healthy discussion and suggestions on how we can improve the RMNCH as well as immunization services in difficult situations. We can build on the recommendations emerging out of today's interaction to further develop our collaborative partnerships so that the 2 neighboring countries can grow together and bring much needed peace and prosperity to the region. Thank you once again for giving me this opportunity to share the Pakistan's perspective.
Thank you so much, Dr. Anas Safdar and Dr. Shafiq Mirzazada. May I please request Dr. Zulfikar Bhutta to please enlighten us with the key findings and evidence gaps of Afghanistan and Pakistan regional context. Dr. Bhutta is the co-director and director of research at the SICKID Center for Global Child Health and founding director at the Institute for Global Health and Development at the Aga Khan University. Dr. Bhutta is a distinguished national professor of the government of Pakistan, co-chair of the Maternal and Child Health Oversight Committee of World Health Organization, Eastern Mediterranean Region, and the Coalition of Centers and Global Child Health Chairman, as well as core member of the BRANCH Consortium. Dr. Bhutta will be joined by Dr. Carl Blanchet. Dr. Carl is the director of the Geneva Center for Humanitarian Crisis Center at the London School of Hygiene and Tropical Medicine, and is also a core member of the BRANCH Consortium. Over to you, Dr. Bhutta.
I just want to make sure that you can see my slides. Can you?
Yes, we can see it.
All right, and can you see them in full screen?
No, Dr. Bhutta, it's coming on the projection format.
I've just changed it, so I just want to be sure that you can see them in full screen. Can you see them now?
Not yet.
Try once again.
We could see them the first time, right in the beginning. They were showing.
Yeah, it should be. Just try once
We can
again.
see, like,
So I'm changing the display settings to a full screen. So let me know when you can see them. Meher, can you see them now?
no, just 2 seconds before that, when you had just clicked on the display and display them, we could see them at that time, but you've again moved to a presenter view.
Very odd. Let me just try one final time. Can you see them now?
Please click on the slideshow option at the very top, at the top of the screen. Yes, this one.
Yeah, you let me know when you can see
We
them.
can see now. We
You
can
can
see now.
see it now. Yes.
Okay, all right. Well, wonderful. So thank you very much for this opportunity, and I'm very grateful to PMNCH for facilitating and making it possible for us to have this joint seminar, and obviously very grateful to the leadership from the Afghanistan and Pakistan Ministries of Health for their encouraging opening remarks. My task is to set the scene along with my colleague Carl Blanchet as to why we did what we did and what are the key findings in terms of their implementation as we take this forward. So a word before we get into the details of what the BRANCH Consortium is. This is an academic research enterprise that we set some years ago now, aimed at improving the evidence and guidance for effective action for women and children's health and nutrition in conflict settings. In addition to its international steering committee of co-investigators, this really includes a lot of researchers based in the conflict-affected countries, collaborators, and also representatives from international humanitarian NGOs and a number of UN agencies. So this partnership spanned about 5 or 6 years before we actually brought some of our products up into the public space. And we've also been collaborating with other research and global advocacy initiatives, and certainly have had a very fruitful partnership with PMNCH, WHO, and UNFPA. The consortium, as I just mentioned, has these core groups that represent some of the leading universities of the world, Stanford, Hopkins, Harvard, Aga Khan, and GWU. We had the honor of coordinating this from SICKIDS in Toronto and Aga Khan University. And also, as I mentioned, it has a lot of these additional partners that I have already spoken about. The activities focus on basically what can be done to fill the global evidence gap and knowledge gap in relation to what can be done for women and children in conflict settings. So the work that we undertook was sequential. We looked at what were the estimation of burden of reproductive maternal child health and nutrition related morbidity and mortality that could be directly or indirectly attributed to conflict. And this took several years and several sequential publications. We looked at, along with WHO and UNICEF, a critical look at the existing guidelines and normative guidance for documents. And we also involved a number of NGOs in this process to look at what existed. But in addition, we undertook a number of systematic reviews that I'll mention shortly that looked at relevant maternal, child, and adolescent health nutrition interventions and their effectiveness from what was available in conflict settings and within these contexts that I'm just talking about, and specifically focused on what were the innovations and implementation delivery strategies that could increase the effectiveness of those interventions. Not being satisfied with just doing this as a desk exercise, we actively undertook prospective country case studies. We worked with collaborators and partners, and my colleague, Professor Paul Blanchet, will detail some of that in his presentation shortly following mine. And this was mixed method studies. We not only looked at quantitative data on what was actually happening on the ground, but we also looked at what was the process of decision making and mixed methods in terms of assessing their effectiveness. Obviously, all of that also led to pointing out where the gaps were and what needed to be filled prospectively through implementation research, something that partners will take on, and we attempted to put forward all of this in a manner that would help and guide the field. Extensive list of publications, but two large collections I would particularly point out. One is that all the country case studies are available in open access in conflict and health. These 10 country case studies are listed here, and the web link is also provided. And these are a very rich source of information, as you'll hear from Professor Blanchet. On the systematic reviews that we undertook, there were 8 specific reviews on interventions and intervention delivery strategies that were published in the BMJ as a collection. And that's also available. You just need to type the URL bmj.com/branch and you will get them. But our crowning effort was this Lancet series on conflicts in conflict settings and humanitarian emergencies. And actually, although this was published online several months ago and we had a launch, the formal paper publication just came out this week. So the timing of this workshop is critical. And the Guardian highlighted some of this work yesterday in quite prominently. So we had 4 papers and a linked comment. And I'm told that the comment has had quite a lot of traction because people have focused on what needs to be done. The first paper looked at burden and epidemiology in the context of political insecurity and changing nature of conflict. The second paper on the numbers. The third on interventions, specifically in such settings. The fourth is specifically related to the country case studies, the third and fourth, and then the comment on what we need to do in taking things forward. And we were very pleased to have a linked comment to the series by none other than Helen Clark, who is needs no introduction, former Prime Minister of New Zealand and the chair of the PMNCH board, has been in the forefront of advocacy for women, children, and adolescents globally. So I'm going to talk very briefly in terms of what these broad papers covered, and I'm going to talk about paper 2 and the one that relates to interventions. So firstly, what are the effects of armed conflict on women and children? Big ticket numbers. Now, we had in the linked papers to this related to maternal and child mortality that were published a couple of years ago, looked at the context of child mortality for Africa in relation to conflict. And we also followed that with an empiric analysis of what was the situation with maternal mortality. And these geospatial maps of Africa just tell you how the clustering of deaths in relation to proximity of conflict varies even at national level. So although we may talk about one country as being homogeneous in terms of its mortality distribution, as you can see in many large countries, and particularly notice here, in the context of conflict that spans many boundaries and zones, South Sudan being the case in context, look at how the impact of conflict transcends even national boundaries. And you see this not just for child, but you also see this quite clearly in the context of maternal mortality. And the bottom line is that between 1995 and 2015, our estimates were that over 11 million deaths of women and children in Africa could be attributed to direct and indirect effects of conflict, and women being those that were related to childbirth and pregnancy. We also looked at what really mattered, and what clearly came out is that proximity to a conflict, how close you were to the epicenter of conflict, really had a huge effect, not just in fact in terms of direct impact of conflict, but a ripple effect in terms of how it disrupted services and health systems. Now, to people on the ground, this is already well known, but it was quantified in this process. And what you can see very clearly here is that both in terms of chronicity of conflict over time, and also in terms of proximity to the conflict itself, there is a gradient. So the longer the conflict, the greater the impact, and the closer you are to the center of the conflict, the greater the impact. So within 50 kilometers, you see such a huge impact, but you also see that increasing between 50 to 100 kilometers of the conflict epicenter. And that's one of the reasons why we need to be very cognizant of the geography and distance relationship. So we believe that in this time period that I've just mentioned, using Africa again, that 3 to 3.5 times the number of deaths in children were due to the indirect effects of conflict. So these are things that relate to disruption of services, immunizations, other interventions, etc. It was important to put a number to it. We also looked at this in the broad global context, other than Africa. We've already spoken about Africa, but as you can see today, we are speaking about the Afghanistan and Pakistan region, and you can see the clustering of conflict in our border areas and in geographies, but not just limited to those. I mean, they are also impacting other geographic locations. And Asia is not immune to the effects of armed conflict, and so are parts of Latin America. As I've already mentioned, very specifically, just honing in on infant and newborn mortality in the context of distance. So if you look at the risks of infant mortality within 50 kilometers of the conflict, look at various regions, Asia, Africa, Americas, and combined, that the risks in terms of severity and distance are about 14 to 26% higher in those areas which are relatively close to conflict. And the causes of those I've already alluded to. So the key message is that the number of children who are affected by armed conflict in these very geographies has grown steadily over the last 20 years. And this is a combination of both population size, the urbanization of many of these conflicts, which are taking place now in cities rather than in rural areas, and a steady increase in conflict events. I mean, we may not have the world wars, but we have forever wars. And today we are talking about Afghanistan and Pakistan. Imagine that this area has been in turmoil for now close to almost 40 years. I actually started my clinical career in an Afghan refugee camp in 1979. And you can imagine that this has affected close to around 600 million women and children, almost 10 to 16% of the total numbers worldwide. I've already mentioned that overall, we believe that more than 10 million deaths in children under 5 years can be attributed to conflict between 1995 and 2015. So this is not trivial. And many of the consequences of conflict are responsible for a lot more, which we don't yet have a very good number on. This physical injuries, disabilities, mental health issues, chronic non-communicable diseases that may have their origins in some of that early exposure, particularly mental health, and also sexual and reproductive health consequences. So I want to turn very quickly on to the interventions, what can be done. And our main interest was to try and define, if we could, through a systematic process, what was the nature of the evidence around interventions and their delivery patterns in these settings. And we came up with a decision-making framework that could be adopted in many of these settings in a logical manner, where you start with a situational analysis. What does exist? What was there prior to conflict or at the same time? What needs to be addressed as a priority? Are there any outstanding issues that you should be aware of as you go in. And then what is it that's feasible and logical? Obviously, you will not be doing liver transplantation in conflict settings, but are there interventions to address trauma and needs that can be prioritized in those settings? Are there interventions to address newborn survival or adolescent health issues that can be prioritized in those settings? And importantly, not just looking at things that will save lives, but things that also will save brains. So we are very aware of the fact that we now have enough knowledge to perhaps implement and scale up some of these mental health interventions that were hitherto restricted to only stable circumstances and often too late for people. And we were very focused in a way on how can these be prioritized in those settings through a decision-making process that I will let Professor Blanchet speak to. I've already alluded to some of these interventions being clustered in certain areas, and as you can see from the core epicenter of the conflict to relatively stable areas, most of the stable areas are where the camps are. You never set up a refugee camp in the middle of an ongoing conflict. You set them up in a safe distance, and that's why the vast majority of the evidence of interventions that we have in conflict settings stems from those stable circumstances. But we believe that that's only a fraction of people affected by conflict. The vast majority of people are in the intermediate zones, which is, insecure, but not in the middle of maybe, full-scale bombardment. And as we have seen during the last several conflicts in the Middle East and in Afghanistan and Pakistan also, sometimes people don't move. They stay where they are, particularly in large urban settings. And therefore, you are increasingly also dealing with provision of services in the middle of an ongoing conflict in certain areas. And they can be life-saving interventions that you can focus on. When we looked at all the potential possible interventions, given the limitation of the existing evidence from the field, it was possible for us to prioritize some interventions given a particular context by area. So even where the conflict was raging, we could identify interventions that were potentially feasible and implementable in community settings. These are through community outreach workers. What could you do to save lives? What could you do to provide care and support, even in those settings? And as you can see, once you move away from the epicenter, we are able to identify close to 100 interventions that can be done through community outreach workers. And these don't have to be lay workers. They can also be things like people like technicians. They can be people like health workers who have been reasonably trained, who can provide outreach and support to many of those settings. And we find that the evidence around their effectiveness is growing in both community and primary care levels. So if you look at the bulk of the interventions that we have underscored as being important, they're not necessarily in tertiary hospitals, but they are in those settings of community and primary care facilities. So the key messages from the interventions piece was that a lot is possible, but it needs to be put together. And therefore, the agencies, both the UN and bilaterals, as well as NGOs, need to get together to look at the evidence and guidance for delivering effective health and nutrition interventions in conflict settings. And a framework such as the one that I've just identified to you, what can be prioritized for high intensity conflict, intermediate areas, and safe areas, would allow you to develop packages of care that are feasible to be delivered and at low cost. These should be dependent upon human and material resources. If you have already people on the ground, such as community health workers who are doing certain things, then making them aware of packages that can be delivered without overloading them is logical. If you don't have surgeons in the field, you could train technicians to provide emergency care and first aid and support for trauma that can be important in such settings. And of course, interventions to evacuate and move people to safe circumstances. We are making a very strong recommendation that this needs to be led by people on the ground. So we are calling upon the global humanitarian NGOs and local academia working in those geographies to work together to establish a process in which we have actually called for an independent technical advisory group representing all of these stakeholders to look at some of this evidence and develop packages of care as we move forward. And And we would be very happy to support this process, but it needs to be led by this large multi-stakeholder group. Our next steps are knowledge translation. How do we make sure that all of this work that we've done over the last several years can be translated into effective policy and implementation? And some of that is through our collaboration with PMNCH to develop these knowledge briefs and advocacy toolkits, which I hope will not sit on a shelf, but will be actively used by people like yourselves in the field, looking at the evidence around what we need to do and how and when. And this entire exercise will now lead to translation in particular contexts. So we are aiming for 3 advocacy and planning workshops. First one of which is happening today with this virtual workshop that we thought might be at one stage a face-to-face workshop, but COVID has precluded this. And we're going to do one in Africa and one in Middle East and North Africa. So without further ado, let me pass to my colleague, Professor Blanchet, who led a very large team looking at country case studies and as to what could be done and what have we learned from this. So over to you, Carl.
Thank you very much, Zufi. Next one. So what we have done is actually we went to the 10 most affected countries affected by conflict. And of course, you can see on the list Afghanistan and Pakistan. And we were more than 85 researchers and 24 different institutions. You have seen on Zufi's slide that the BRANCH Consortium is composed of Western universities plus Aga Khan University. But as well, what we did in each country, we were working with a national university. So we were 24 institutions trying to bring some evidence. The evidence we tried to bring through the different case studies was actually to try to explain why some interventions had been delivered and why other interventions actually had not been delivered in time or at the coverage we were expecting. Next one. So we look at all the spectrum of mother and child health and adolescent health interventions to try to look at what we know in terms of evidence and trying to see which interventions were delivered and where and why or why not. And so we looked at in terms of explanation, trying to understand what were the motivations behind the decisions made of not delivering or of delivering, and what were the challenges to deliver in some of the contexts. Security has been mentioned a few times in the introductions by the Deputy Minister, Dr. Mizazada, but as well, there are some other bottlenecks that may be linked to governance or internal politics or agendas. And finally, we try to look at in a more positive way at the solutions that had been introduced by local actors and international actors. Some of the innovations in terms of interventions, but as well the way of working. How can we deliver some of the interventions in some of the most challenging, unstable settings? The one that Professor Bhuta described, the one that are very unstable, where population are moving, but as well where level of insecurity is very high. Next one. So we looked at all the different countries, and you can see on the list Afghanistan and Pakistan, and trying to identify the most striking bottlenecks in this kind of environment. And of course, as you can imagine, as we move forward today in August 2021, this analysis is going to evolve over time with a changing situation in countries and very rapidly today in Afghanistan. Next one. Some of the I would like to highlight today some of the solutions that had been identified by actors. And today, when I talk about actors, is all the humanitarian organizations coming from the outside to try to provide assistance. But beyond that, we have all the local providers, the ones that have been employed by the Ministry of Health, the Ministry of Public Health in countries, but as well all these local organizations working on the front line and providing services to populations. Some of the key, I would like to highlight some of the key innovations in terms of remote management. When people work, for example, in northern Pakistan or in some region of Afghanistan, trying to, when we do not have access to populations, we've seen in many regions where we had team of professionals working with local providers and providing some remote advice, but as well making sure they have access to the essential basic medicine in some places. We have seen that in Somalia, we have seen that in Syria, northern Syria, but as well in Pakistan. And my recent trip to Afghanistan, we had a lot of conversations with Aga Khan Health Services, where they explain how they work in Taliban control areas, for example. But as well, there are many other innovations related to access to healthcare, how to bring services closer to populations. And of course, in this kind of situation, and more strikingly for mother and child health services, it's very important to value community health workers. And that's some of the aspects and some of the innovations that have been implemented, either working directly with community health workers or using mobile clinics in some of the most remote areas of the country. That's the case in Afghanistan, in some of the most mountainous regions, but as well in other aspects, in other areas of the country. And finally, when we talk about capacity building and skills of clinical staff or non-clinical staff, very important to consider some of the key innovations that have been tested in many countries like Yemen and Syria, where people have used telemedicine, but as well online courses in order to coach and mentor some of the clinicians working on the front line. This has been done in the most difficult situations or disciplines like surgery, for example. So we do think that in the BRANCH Consortium, it's important to explore some of these key techniques and approaches to value what people are doing and to increase the quality of care. Next one. What we have seen is that some of the key interventions have not been delivered, and one of the key populations strikingly ignored, or not ignored, but neglected, are the adolescents. And that's in a recent move with PMNCH and the BMJ is actually to value adolescent health and try to make sure that we can reconsider in our approach adolescents as a center of the mother and child health interventions. What we've seen as well is that donors are playing an important role, too important role in many cases. Professor Bhuta was highlighting the need for identifying the needs, identifying the capacity of the health system and local actors in order to shape the way interventions are going to be delivered and which interventions should be delivered. Unfortunately, we have seen in the 10 countries that donors are playing a key role, and they have an agenda and key priorities. And this has a huge influence on the level of funding we can get access to and on the type of interventions that are delivered. Predefined packages or priority packages of services have been applied in a few countries, but not in many. Afghanistan is currently doing through the finalization of one of them. I know that Pakistan has done the same exercise as well. Somalia have done it, but this has not been done in many countries. We have seen that priority packages can offer a space to help and facilitate decisions made by providers and by government. So that's something that we would like to explore. And as Professor Bhuta explained, we have highlighted some of the key priorities in the BRANCH Consortium that could help people or providers and professionals make quick decisions. Next one, and my final slide. Finally, what we have seen in many countries is the emerging role of non-state actors, and that's very clear today in Afghanistan. But the key aspect for us is how to work with non-state actors to make sure that the disruption of services is going to be less damaging or less frequent or long, to make sure that access to care can be actually protected. And as highlighted in one of my slides, whatever the challenges that we have seen that many creative solutions had been found by humanitarian actors and national actors. And that's something as well we need to value. However, to try to document all these beautiful or very effective interventions, we need to find a place in order to systematically document what is going on, so that this experience can be shared in other contexts or in other countries. And one of the key messages from the BRANCH Consortium is about national and local actors. The humanitarian system is too much led by international organizations. They have the voice of local and national actors is actually not valued enough. And I think what we think in the consortium is that a lot is going on, but we need to make sure that we can document what local actors are doing in order to learn more from this experience, and that we can be more effective and efficient in many contexts. Thank you.
Thank you very much, Carl. And as I finish, I just want to highlight that the resources for a lot of what we have presented, all the papers and all the PowerPoints are available on the BRANCH Consortium website. And I would encourage you to visit that. And if you have any specific questions, to revert to myself and to Professor Blanchet as you deem fit. Thank you very much. We haven't set time aside for questions and answers here, but we will have ample time in the breakout groups and the broad discussion that will follow. So back to you, Oscar.
Thank you very much, Dr. Bhutta and Dr. Karl. I will now invite Dr. Shafiq Mirzazada and Dr. Jaidas to share key findings and implications of Afghanistan and Pakistan country case studies. Dr. Shafiq Mirzazada is the Deputy Minister of Public Health in Afghanistan. Dr. Jai is an assistant professor with the Center of Excellence in Women and Child Health, and he's also the section head of the Public Health and Epidemiology at the Aga Khan University. Over to you, Dr. Shafiq.
Thank you, Asghar. Jay, would please put the slides on the slideshow mode. Now we can see the presentation mode, so if you can change that. Jay?
Please click on End Slideshow and click on Slideshow option once again.
Jay, click on the slideshow down, just down, like Zoom, yes, here.
Please click on the option.
No.
So perhaps you could put the slides up for Jay if you have them.
So I'm trying to do that, but
Okay, so Jay, can you please click on the slide, please end the slideshow option. Please click on the end slideshow. Okay. Please click on the slideshow button, which is the 7th option, just right next to the animations option. Please come on top. Okay. Yes.
Right. Okay.
And there is this slideshow option. If you click on it, yeah, please uncheck this use presenter view option, which is yes. Come more right. Yes. More right. Yes, yes, yes. Uncheck this use presenter view option, please. This one on your left. Yes. Yes, on your left.
Use
Use
present.
yeah, please
Uncheck
check it.
this.
And then click on slideshow option again. Yes.
Okay, I've done that now.
Now,
Please start from the beginning. Yes, click on the first slide and then click on slideshow option again.
I'm clicking
I
on it.
believe your laptop is a little bit slow. It's taking time.
Okay. Shamsa, you have these slides if you can share.
Yeah, sure.
Yeah.
So you unshare, please, Jay.
Just stop sharing. Yep.
Great. Okay. Thank you very much, Asghar, Dr. Kaul, and Dr. Butta. If you go to the first slide, please. I'm going to present the case study for Afghanistan, but here I'm wearing another hat. So, because I was the part of the study team, the research team, before I joined the Ministry of Public Health. So I'm presenting on that capacity, and I hope I can do justice to the team presenting the case study for Afghanistan. And as you can see, the team included colleagues from different organizations. Next slide, please. I'm going to present the Afghanistan and then followed by Dr. Jay Das on the Pakistan case study. A little bit of the background, as we all know, that Afghanistan and Pakistan failed to achieve the MDG 4 and 5, unfortunately. This, of course, was due to many different reasons, one of which might have been the conflict, and both countries are impacted by long-term conflict in certain geographies, Afghanistan more so. And also high burden of maternal and child morbidity and mortality, as we know that Afghanistan specifically has the highest mortality in the region when it comes to maternal and child mortalities. High burden of nutrition. I think we also know from the latest surveys that undernutrition is very prevalent, though there has been improvement in nutrition status of women and children, but still it is an issue and a burden on the health system and on the population. And of course, the socioeconomic indicators within the countries are also impacted and erupted. Next slide, please. Next. Just to look back to the 4 decades of conflict in Afghanistan and the chronology of different events that has happened since a long time after the ousting of the kingdom in the country, and then the 1978 changes that has happened with the invasion by the Soviet Union in the country. and its initiation of the war against the Soviets and the Soviet-backed government, till they withdrew from Afghanistan, and after a few years the government fall and Mujahideen took over the government, but unfortunately things got worse. The civil war started, and then of course the Taliban movement started with the aim to bring peace to the country, but it also ended into more conflict, unfortunately, in the country till, 2001 and the fall of Taliban and so on. I think I'm not going to go into details of all these, but we know in the recent years what happened over time. Till now that we know the conflict is even further escalating, but the good thing is that the peace negotiation has started, and we hope that this will have a result, a good end for the people of the country with ending the conflict, the long-lasting conflict. Next, please. Next slide. Shamsa. Thank you. As it was explained by our colleagues, that the BRANCH Consortium, one of the series of publications which were done was to do case studies in 10 countries, conflict-affected countries, one of which was Afghanistan. And in the study, we used a mixed method for the study, and for the quantitative data, we used the data sets from the two important surveys in Afghanistan: the mixed survey 2003 and 2010, and the DHS Demographic and Health Survey in 2015. The reason we used these surveys and these data sets because of their standard methodology and reliability and consistent definition of indicators. In order to look at the conflict and impact of conflict on the RMNCH services, we used two methodology to basically categorize conflict in the country. One was through the Uppsala system, where the battle-related deaths, we took that, and wherever there were less than 100 deaths, those areas were ranked as minimal conflict, and between 100 and 300 moderate, and over 300 severe conflict affected areas. But in the meanwhile, we use a Delphi technique where we ranked the provinces based on key stakeholders, responses using the Delphi technique between 2003 to 2010 and 2010 to 2018, and categorize these areas into these three conflict categories: minimal, moderate, and severe. I'm not going to go through the different analysis methodology that we used. We used the stratified descriptive analysis for coverage of on RMNCH indicator. We also use the composite coverage index to look at the group of the indicators, and so on. Next slide. Thank you. Looking at the child mortality based on the analysis from the three surveys, we know that despite conflict prevalence in the country, as I said in my opening remarks, the country has had significant improvement in health indicators, and one of which is child mortality. We can see that between 2003 and 2015, there has been significant improvement and reduction in child mortality, both infant and under 5 mortality. And the latest survey, which is the Afghanistan Demographic and Health Survey, shows 55 deaths per 1,000 for under 5 mortality and 45 infant per 1,000 live births infant mortality rates. Next slide. Sorry. Thank you. With regards to the nutrition status of children, as I highlighted earlier, that there has been improvement in the child nutrition in terms of the underweight prevalence and stunting and wasting. But still this remain a challenge for the country, and this also comes from the mixed surveys as well as the national nutrition surveys, and the latest was the 2013 survey, which shows significant improvement in those areas. Next, please. In terms of reproductive health, the indicators such as the contraceptive prevalence rate, skilled attendance and delivery, and antenatal care. Data, we can see that there are significant improvement in these areas, except contraceptive prevalence rate, as we know that there are many factors, contributors towards that, there hasn't been that much improvement in contraceptive prevalence. And these factors has been cultural and religious and other factors. Next. With regards to the scale and timeline of conflict, we looked at the data set as I explained earlier in terms of the battle-related deaths. We can see that there has been an escalation of conflict throughout these years till the latest date, which is year 2019. And these are from the Uppsala database that has been taken. Next. And with the escalation in conflict, we can see that there has been displacement of the population within the country in different regions. More and more displacement over the year as the conflict escalated. Next, please. This slide shows the geographic distribution of the conflict in the country between 2003 to 2010 and 2010 to 18, after we conducted the Delphi technique exercise. But of course, the map looked very different now if you look at that. Next slide, please. In terms of the trends for the reproductive and maternal interventions from 2003 and to 2015, we can see that there has been improvement in these interventions, provision of ANC by skilled provider, family facility deliveries, skilled birth attendants, except, as I mentioned earlier, the contraceptive prevalence rate, which has not had sufficient improvement within these years. Next. This slide showed the increase in the coverage of various essential RMNCH interventions from period of 2003 to 2015. And we can see that compared to the provinces where they were affected by severe conflict, the gains of coverage for most of the indicators have been higher in the provinces with minimal conflict, except for contraceptives, as I mentioned. And these effects are significantly, statistically significant, confirming that the severity of conflict is directly related to the health services. So with this, I will hand over to Jay to continue with the Pakistan case study before we conclude. Thank you.
So thank you. Thank you, Shafiq. So regarding Pakistan, Pakistan has had a different period of conflicts when you compare it to Afghanistan, because what Afghanistan has been experiencing is a widespread conflict sustained over a very long period of time. But if you see in Pakistan, there have been various different sorts of conflict, and these have impacted various geographic locations within Pakistan and over a different span of time. These started just at the existence of Pakistan when there was conflicts at the partition time. Then Pakistan has experienced some wars with its neighbor. There has been civil war eruptions in part of Pakistan, especially in Balochistan in the 70s. And recently, the war on terror led to various internal conflicts with anti-state elements doing isolated activities in specific areas of Pakistan. And these have been ongoing for the last 2 decades. So apart from these, there have been various military coups, there has been sectarian and ethnic violence. And apart from this conflict, there has been humanitarian emergencies, including earthquakes and floods. So a study showed that since the year 2002, Pakistan has faced more than 90,000 people have died due to terrorism and other related events. And the economic cost of just this has been estimated to be around $120 billion. So this can briefly summarize what the impact of conflict has been, not on the human life and other factors, but as an economic growth of a country. Next slide, please. So compared to the Afghanistan, you can see that the number of scale and the number of events have been less, and we can see that the peak of conflict-related events was highest in the year 2010, and gladly these events have been reducing over the years in Pakistan. And if you see in the next slide please, you can see the battle-related deaths, and you can see that there has been a significant decline in the deaths due to these events, which were at its peak in the year 2010. And since then, due to various major measures taken by the government in collaboration with various stakeholders, it has led to a decline in the events and also a subsequent decline in the battle-related deaths. Next slide, please. This figure also corresponds to the earlier 2 figures that I showed. And you can see that the displacements were also maximum in the year 2014. And after that, there has been a decline in the people who have been displaced, whether internally or externally, due to conflict. Next slide. Okay, and you can see that most of the population who's affected by this displacement are the adolescent population, and to a certain extent, children and females are also affected. Next slide. So the quantitative analysis was similar as to the approach taken in the Afghanistan case study. And here we also use the Pakistan demographic health survey data from 2 years. And the same techniques were used. But in here, the difference was that we did not categorize the provinces, but we categorized the districts of Balochistan and FATA, because these were the two areas which were heavily affected by conflict. So we have based this analysis in Pakistan just on the province of Balochistan and previously FATA, which is now recently merged with KPK. So similar sort of analysis was done as we did for Afghanistan. Next slide, please. So we can see that Pakistan has made progress over the years, though not what was needed, but there have been decline in the child mortality rates over the years. Next slide, please. And when we see the child nutrition indicators, Pakistan still has a high burden of childhood undernutrition, whether it's stunting, underweight, and wasting. And the progress over the years have not been very encouraging, and still we face a high burden of undernutrition, as around 40% of the children are stunted, around 29% are underweight, and the wasting prevalence rate is also high at around 18%. Next slide. When you look at the coverage of various interventions, essential interventions for women during their pregnancy, we see that the coverages of a few interventions, though has increased, but still it's far from optimal, and we are lagging behind still to achieve the universal health coverage targets. Next slide. So this is a slide in which we categorize the districts and areas of FATA and Balochistan. The regions marked with red show the areas which were heavily affected by conflict, and the other districts are marked as comparatively or relatively lower conflict or lower severity of conflict compared to these districts. Next slide. So as we did not have any data for FATA, because there's no household survey being done over the years in that region, so our analysis for the impact of conflict on the coverage of various essential interventions was limited only to Balochistan. And this figure shows that what was the coverage increase in these essential interventions over the period of 2006 and 2012. And this was the period where Pakistan faced the maximum conflict and maximal events and deaths due to conflict. What we can see is this shows a clear indication that the districts which were affected severely by conflict showed a minimal improvement in the coverage of various essential interventions compared to the districts which had minimal conflict. And also you can see that statistically this impact is significant. So we quantify by this methodology, we actually quantified the understanding that conflict has on the coverage of essential interventions. And you can see that for a few indicators, the impact or the difference in coverage is very high. Looking at immunizations, care seeking for ARI, there's a wide difference between districts which are heavily affected by conflict. Next slide, please. So as part of this, we also did a qualitative exercise in which we interviewed various stakeholders. These included government officials, NGOs working in that area, development partners, academia, and we tried to identify what are the major issues or major bottlenecks or challenges that they face in implementing these maternal and child health services. And what we found was, I'll just summarize a few key themes that we found, was that one of the major areas that found was that the people working on the field thought that the prioritization of interventions which should be implemented in those areas was done without the consensus of the people who are actually working in those areas. And mostly it follows a top-down approach rather than a down-up approach. And we also saw that there were issues with supplies and commodities, which led to stockouts, delayed procurement and delayed supplies. There were issues with coordination among various stakeholders who are working in that area, including the government, NGOs, and the development partners. A major issue identified was with the health workforce, and people working had issues in identifying the health workforce, retaining them, and especially identifying and retaining female health workers in those areas was a major barrier. There was issues with budgeting, finance, and apart from that, then there was some social cultural context, which varies by the regions. And one of the issues that identified was the monitoring and evaluation of all the programs that have been implemented was not up to the mark, and more needs to be done so that the programs could actively adapt to the needs, or to the current needs of the program. Next slide. So with this, I'll just conclude both the case studies of Afghanistan and Pakistan, and we see that the conflict does have an impact, and that impact is significant, whether it in terms of, if you can see the coverage of essential interventions or its impact on morbidity and mortality. And the progress in this is hampered by weak stewardship, poor infrastructure, limited health workforce, and poor coordination and monitoring. So the government needs to take a more collaborative approach and improve decision-making and strategic planning at this level for sustainable health outcome in such conflict contexts. So with this, I'd like to conclude, and thank you all.
Thank you very much, Dr. Jay and Dr. Shafiq. May I now invite Dr. Wais Karani and Dr. Nabila Ali to kindly share regional perspective of implementation and service delivery for Afghanistan and Pakistan. Dr. Wais is the Director for the Division of Nursing Services, Afghanistan Nurses and Midwives Council, and President of the Afghanistan Nurses and Midwives Council. He brings extensive nursing management experience in education and healthcare provision. Dr. Nabila Ali brings over 3 decades of seasoned experience with government and non-government sectors for effective health programming in Pakistan. She's an expert in public health and system strengthening for RMNCH and global health security. Over to you, Dr. Wais and Dr. Nabila.
Thank you very much. Thank you for the opportunity. Hello, everyone. It is a pleasure to be part of this important session to discuss on the challenges encountered by the frontline workers. And definitely these challenges impacting the service delivery. There are many common and generic challenges we are talking every day that causing burnout and moral distress for the nurses and midwives. And these challenges negatively affect the quality of the care for women and children. Some of these challenges may include poor working conditions, long working hours and high workload, unstandardized nurse-patient ratio, safety issues, and importantly, security, which I will focus later. Furthermore, the quality and level of education significantly and specifically of our midwives and how much they are exposed to the new knowledge does affect the outcome of the services which we provide. This is again an overlooked area in our case. With the spread of COVID-19 pandemic, these challenges were further augmented, considering that our frontline workers are always at risk and our health systems were not prepared for such emergencies, and the resources are limited. In regard to the security situation, I would like to share a few important points which have badly affected the Afghan health system. These points were also highlighted during the UN Security Council's special meeting on Afghanistan, which was held on August 6, 2021. Unfortunately, Afghanistan is experiencing devastation back into zero. These days, there are 50% increase in civilian casualties. There are human rights abuses, and more than 1,000 casualties are reported just during last month in 3 areas. Hospitals, other infrastructure are being destroyed. Migration, number of IPDs have significantly raised. The situation has badly affected the system of delivery, and unfortunately, there are many instances that have been directly experienced by our healthcare providers, mainly nurses in Middle East during last month. Few examples could be that in Nimrose, a house was looted, a rocket hit Wardak Hospital, a midwife was killed during active shooting, and a number of vaccinators were killed in Ningrahar. Midwives, their family want in Paktika to not to go for the job duties. And Daikundi, in one of the hospitals, no women can visit the hospital. The number of patients in Kandahar Regional Hospital has the 20 to 30 patients, while previously it was 1,000 to 1,500 patients per day. Women are not allowed to visit the hospital without escort. And many other challenges and issues are faced today by the people and health workers. And this is despite that during last 2 days, the conflict and aggression are further extended to many other provinces in the country. These challenges and devastations are indirectly impacting the health of women and children, including the healthcare workers in all aspects of the. And the current situation for Afghans, survival is a matter instead of preserving other things. There is a dire need for the humanitarian assistance for more than half of the Afghan population who are living in these affected areas. In conclusion, I can say that I believe that Afghanistan is in need to be supported in these policy dialogues on women and child health more than any other time, and our intervention would focus on the current scenarios. Thank you.
Thank you very much, Dr. Wiles. May I please request Dr. Nabila to take over?
Assalamu alaikum, everybody, and thank you to the organizers for inviting me. I'm just sharing the screen now. Okay. So I'm going to talk about the barriers and some of the facilitators who deliver effective services in conflict areas and in remote marginalized areas. And I would like to start with one barrier, which is our budgeting process. Because what we have seen is that this can largely be overlooked and is often not reflective of actual population and health management needs. So incremental budgeting is preferred, which means that every year you add 10% or 15% as an increase in the budget, which is not reflective of the needs.
I'm sorry to interrupt, Dr. Nabila. Your slides are appearing on presentation mode. Can they be switched to the slideshow, please?
Dr. Nabila, you need to end the slideshow. Shamsa, if you have the presentation, can you share it from your end?
I think we can do it up. Can you, is this better? Can you see that or not?
We can
Otherwise,
see.
Shamsa, can you do that, please? Because what I can see is slideshow.
Yes, Dr. Nabila, you can exit the slideshow. I'll run the slides from here.
Okay. Okay. Thank you so much. So now you will have to go to the next slide.
Sure.
So I was towards the very end of the slide that output-based budgeting or medium-term budgetary frameworks, when they are followed and institutionalized, we have seen that districts, they contribute in the preparation of budgets. If they have the local understanding, if their capacity is built, the results are mostly encouraging. Next slide, please. And we saw working with Department of Health SIN for 5 years that the budgets they increase because we built their capacity. They came up with all the 29 districts. They came up with their own budgets, and we saw 187% increase in primary healthcare allocations. And ever since 2018 that the project ended, they are like on the rise. Next, please. The next barrier that can be turned into an opportunity is lack of qualified, skilled healthcare workers. It is a barrier to deliver essential RMNCH services. And this we find, this is where the things they crack. The human resource shortages they're further exacerbated in conflict settings. We have seen that at the AFPAC border and in the remote districts, it is very difficult to deliver basic health services because it's difficult to retain the staff over there. And in the communities where there's high level of insecurity, supply chain gets disrupted, and placement of consultants or specialists, is a challenge. As a result, we see a lot of posts lying vacant, which are specialist posts. And there's inequitable distribution of pediatricians, gynecologists. Mostly they want to be posted in urban settings and cosmopolitan cities. And in the rural and far-flung districts, we find that there are human resource gaps. The policy, again, we see that female healthcare providers, they're very, very essential at the community level, like community midwives and lady health workers. And we feel that in the conflict zones, their numbers are very, very less. And even then, their mobility is compromised. So as a result, the services that have to be provided to women, they get compromised. And on top of that, in case of, I would also call it a conflict, or an emergency period when COVID-19 affected our program activities, there was a policy decision to close all outpatient departments, which led to low use of health services because women, they were not coming forward. Next, please. So you can see that first, I will just share with you that you can see that the consultants or the specialist posts, they are less than 40% of the health facilities. They have 60%, they do not have specialist posts available for services. Next. And if you look at the trends in child health indicators, because most of the deliveries, like more than 70%, they take place in rural communities. And you can see the neonatal mortality in the last 3 decades. You can see all the Pakistan Demographic Health Survey trends. It shows that there has been very little decline in newborn mortality because we do not have skilled providers at the place where they're needed, and the interventions are also not introduced at that level. As a result, we see that the services, they're kind of static for the last 3 decades. And we see the neonatal mortality as a reflection of that is not improving. Next, please. Coming to the family planning services, on one hand, we also always talk about the demand side and the supply side, but you can see that there is demand for services. We still have unmet need for family planning, which is 17% according to the latest PDHS. And this 17%, if we, in absolute numbers, is approximately 16 million women of childbearing age, who otherwise would want to space but do not have access to the services or contraception. So you can see that the uptake of family planning services is very, very low, and it's continuing that way. Next. Now, the effect of COVID pandemic on maternal healthcare services, we compared the January to December 2019 routine information system with 2020 for facilities in Khyber Pakhtunkhwa, and we found that there is decline in almost all the indicators which are represented here. Next, please. Coming to the contraceptive stock-out rates, it's appalling. 100% of majority of the methods, they are not available. And in few places there's overload. There are more. The green is where they are more than required. But that's very, very few places where that's the case. Otherwise, the contraceptives are not there because the budgets they got diverted towards, this is KP, they got diverted towards COVID. So as a result, there was no procurement made, last year. So that really disrupts the, family planning program. Next. If you look at stock-out rates in Sindh, they are much better compared to KP because there's use of information. They were looking at the situation and they placed orders for contraceptives, well ahead of time. So we can see a better picture here for Sindh compared to KP. So this is, in a nutshell, this was my last slide. That it's not always the demand side that requires more attention. It is the supply side also where there are gaps. And in Pakistan in 1980s, early 1980s, the primary healthcare infrastructure was built, basic health units, rural health centers and above. But what we see is that now the population has grown many folds ever since. And still the basic health unit are getting, their commodities and supplies according to the 20 to 40,000 population and their catchment area. I think it is time to revisit because there are people who are living outside of health system and they are not even counted in these services. Thank you very much.
Thank you very much, Dr. Weiss.